This lecture is on bone and joint infections, specifically septic arthritis and osteomyelitis. Beginning with septic arthritis, the definition is that of a bacterial joint infection, most often due to hematogenous spread. And these are the common etiologies. Staphylococcus aureus is the most common, and there are also streptococcus species such as strep pyogenes, strep pneumoniae, and strep agalacticae. Gram-negative infections do occur and are more common in the elderly, the immunocompromised, and those with comorbidities. Neisseria gonorrhea is an important cause of septic arthritis and is more likely to be polyarticular. Tuberculosis causes septic arthritis. This is less common and tends to have a longer history and tends to be in large weight-bearing joints. The presentation is with a swollen, warm erythematous joint. The patient is usually weight-bearing and they often have decreased joint movement on examination. Differential diagnosis is broad and includes all the causes of acute arthritis, including gout, drug-induced arthritis, and reactive arthritis. The key investigation is to aspirate the joints, and this must always be done before antibiotics are considered. Joint aspirates should be sent for cell count with differential, a gram stain and culture, and microscopy to look for crystals. Plain X-rays can also be helpful. They'll show tissue swelling and they may show widening of a joint space. In terms of diagnosis and management, first observe the joint aspirate to see if it's purulent. If not, you can initially withhold antibiotics while awaiting microscopy and culture results. Look to see if there's an elevated neutrophil count and/or a positive gram stain. If neither are present, the diagnosis is very unlikely. No antibiotics are needed, and you should investigate the patient for another cause. If, however, there is an elevated neutrophil count and/or a positive gram stain, you should do the same as you would do if you saw that the joint aspirate was purulent, and treat with cloxacillin 2 grams IV. And if the gram stain showed gram-negative cocci suggestive of gonococcus, then you should use ceftriaxone 1 gram. Early source control with surgical drainage by joint washout is vital in these patients. You should follow antibiotic prescribing principles by de-escalating to the appropriate narrow-spectrum antibiotic as soon as sensitivities are available. If the gram stain is negative, you should use at least 2 weeks of intravenous therapy. If you confirm Staph aureus or gram-negative, then 4 weeks of IV therapy are necessary. And if you confirm gonococcal arthritis, the treatment is for 10 days. Moving on to osteomyelitis, the definition is a bacterial infection of the bone, either through direct spread from the surrounding soft tissue, through hematogenous seeding, or direct inoculation into the bone. Common etiologies are Staph aureus and coagulase-negative staphylococci. Occasionally, there will be streptococci, enterococci, or gram-negative organisms. Tuberculosis and fungal infections, particularly in the immunocompromised, can cause osteomyelitis. Osteomyelitis presents with a warm, erythematous, tender swelling over the affected area, but can present with more insidious features such as a limp or inability to walk, especially in children. It's important to send cultures before antibiotics are started. You can send a blood culture and ideally a tissue specimen at incision and drainage during surgery. It's important to realize that plain X-rays can be normal early on in the disease, and a CT scan, bone scan, or MRI may be required when cases are difficult. In terms of diagnosis and management, first ask yourself, is there a surrounding cellulitis or a sepsis syndrome? If not, you can delay antibiotics long enough to obtain a specimen for culture. Ideally, this would be a surgical specimen of bone taken at operation. If there is surrounding cellulitis or a sepsis syndrome, then it's going to be necessary to give early empiric antibiotics, and a good choice would be cloxacillin 2 grams. Then you must obtain a specimen for culture and assess the need for debridement. If antibiotics were initially delayed, once the specimen is taken, then cloxacillin should be started. Once antibiotics are started, you should follow general principles of antibiotic stewardship by de-escalating to the most appropriate narrow-spectrum antibiotic once the sensitivities are available, and the duration of intravenous therapy is typically at least 4 weeks. These are special considerations. Prolonged therapy may be needed in some cases, with up to 6 weeks of intravenous therapy. CRP can be a useful monitoring tool to determine the response to therapy and therefore the duration of treatment. Clindamycin is a good alternative in penicillin allergic patients because it has good bone and soft tissue penetration. And always consider TB or other slow-growing bacteria such as Shigella when patients are not responding to antibiotics. Consider vancomycin in patients who have healthcare-associated infections where MRSA is more likely. Infections associated with prosthetic material, such as hip replacements, require consultation with an expert. So in summary, Staph aureus is the most common cause of septic arthritis and osteomyelitis. Taking tissue cultures or synovial fluid before antibiotics helps in diagnosis and in directing therapy. IV cloxacillin is the initial antibiotic of choice, and prolonged antibiotics of at least 4 weeks are needed in some cases.